Thank you. I'm going to be speaking tonight about prophylactic mastectomies, and I hope to provide you with some information that can help guide you in the decision if you are thinking of having your breasts removed. So what is a prophylactic mastectomy? Well, this involves surgically removing the breast to decrease the chance of developing breast cancer. And when we think about prophylactic mastectomies and breast reconstruction, we typically think about two different types of mastectomies. The skin-sparing mastectomy, which involves removing the majority of the breast tissue, the skin is preserved, and the nipple is removed. Or what you may have heard of or has been talked about today, the nipple-sparing mastectomy, where the majority of the breast tissue is removed, the skin remains, as does the nipple. Now, not all patients are candidates for the nipple-sparing mastectomy, but if you are a candidate for this and meet certain criteria, your plastic surgeon or general surgeon can discuss this with you. So who might want to consider prophylactic mastectomies? This is usually women who are identified as high risk for developing breast cancer. And by high risk, we mean that the likelihood of developing breast cancer is higher than the average woman. We've heard that magic number that 1 in 9 women develop breast cancer in their lifetime, and this equates to 11%. And when we think about high-risk individuals, typically we think of the number as 25%. So if your risk is greater than 25%, then you're deemed to be high risk of developing breast cancer. There are numerous ways that we use to diagnose high risk for breast cancer, assessing breast cancer risk. And the most common tool that we use is the Breast Cancer Risk Assessment Tool. And this has been rigorously studied. It's been developed by the National Cancer Institute, and it's actually available online. And what it does is it plugs in certain criteria or certain numbers: your age, your past history, your personal history, history of any other biopsies or results, and your family history. And then it spits out a number, a percent that can tell you what your risk of developing breast cancer is over your lifetime. So who may fall into the high-risk category? There's generally two groups of women. The first group is women who do not have breast cancer, such as BRCA gene mutation carriers, who can range from 60 to 80% having a lifetime risk of developing breast cancer. Women who have a strong family history of breast cancer, which means that in their immediate family, so their mother, their sister, their daughter, people have breast cancer before the age of 50. There are certain diagnoses, so you may have had a biopsy that isn't cancerous, but it does determine something that puts you at a higher risk for developing breast cancer in the future. Or in some cases, there are some women who have had radiation therapy to the chest wall for treatment of something like lymphoma, and if they've had this at a young age, it can put them at high risk. This group of women consider having bilateral or both breasts removed prophylactically. The next group of women are women who do have a diagnosis of cancer in one breast, and they choose to remove the opposite breast because they're high risk of developing a second cancer or another cancer in the opposite side. And I think it's important to mention a third group of women that may not be deemed as high risk of developing a breast cancer in the other side, but they do have a diagnosis of breast cancer. And due to personal feelings or fear of anxiety of developing breast cancer in the opposite breast, they do choose to remove the breast prophylactically. So how does a prophylactic mastectomy help prevent breast cancer? Well, as I previously mentioned, it removes the majority of the breast tissue. It does not remove all the breast tissue. There's still a thin layer that does remain, so there is still a very, very small risk of developing breast cancer. The group of people that is most rigorously studied is the BRCA1 and 2 gene mutation carriers, and it has been shown that risk reduction can be as high as 95% in this group of people, and in women who have a strong family history, the risk reduction can be as high as 90%. As with any surgery, there are going to be potential risks, and it's important to consider these. So if you're going to consider having your breast removed, there's going to be an elimination of breast function. There will be an inability to breastfeed, and if you're a candidate for the nipple-sparing mastectomy, that nipple is not going to have sensation, it's not going to have erectile or sexual function, and in any woman who chooses to have their breast removed, there's going to be some change in body image, and there is the possibility of having some anxiety or disappointment about changes in your appearance afterwards. A lot of women ask what happens after a prophylactic mastectomy. Do I still need my annual mammograms, my imaging? And the answer is no. There is no further screening imaging that is required with regards to mammograms, ultrasounds, or MRIs. However, if you are deemed to be high risk, such as a gene mutation carrier, then annual follow-up examinations are recommended by a health practitioner. So where does breast reconstruction fit into all this? Whenever possible, we do choose to perform immediate breast reconstruction. which is breast reconstruction at the same time as the mastectomies are taking place. And this is beneficial for women because it avoids a period of time of having no breasts. There are less surgeries. We're able to preserve the skin and sometimes the nipple, which can leave a more natural-looking breast result. And both the use of your implants or your own tissue may be considered with having a prophylactic mastectomy for your reconstruction. So this is an example of a lady who actually had a diagnosis of breast cancer on her left breast. She was to undergo a skin-sparing mastectomy, and due to the high risk of developing a breast cancer on her other side, she chose to have a prophylactic right mastectomy. So she had bilateral skin-sparing mastectomies and reconstruction with pedicle tram flaps, and she's shown 3 months post-op prior to reconstruction of her nipples. This is a lady who was not BRCA positive, but she had a very strong family history. She underwent bilateral nipple-sparing mastectomies and one-stage reconstruction with implants and acellular dermal matrix, and she has shown 1 month post-op. Another question that comes up is, are prophylactic mastectomies and the subsequent or concurrent reconstruction covered under OHIP? And the answer is yes, they are currently covered under our health plan. So who do you talk to if you're thinking of having a prophylactic mastectomy? There are a number of people that are part of the process. First, there's the genetics counselor, genetics specialist that's going to determine the risk status, whether or not you qualify for gene testing. There's a patient care specialist or social workers that help navigate you through the system. The general surgeon who performs the mastectomies and the plastic surgeon who can discuss your options for breast reconstruction. And support groups such as Willow, who has coordinated this event tonight, and the invaluable source of other women who can perhaps provide some insight into their decision-making and how they felt after they went through the procedure. Making the decision is not an easy one. It's a complex and time-consuming process, and I strongly encourage you to take the time to think about it if you are considering it, because it's not an urgent surgery, so make sure that you are well informed, that you have thorough discussions with your general surgeon about your risk reduction that it can offer you personally, and your plastic surgeon to make sure you're confident in your reconstructive choice. It's important to make sure you have a good support network, specifically family and friends, that can help support you with the decision, as well as support you in your post-operative recovery. Thank you.